Hello, everybody. Welcome to Tuesday's edition of Clinical Problem Solvers Video Morning Report. Before we get underway, I'd like to introduce some of our contributors today that are helping us have this session. Without them, we wouldn't be able to host this session. So I want to start with my fabulous co-discussant, Zakariyya. How are you? I know it's good evening time back over in South Africa. How are things there?
Hi everyone, I'm Zakaria. Yeah, I'm slightly was not expecting the time daylight savings time, but still really excited for this case. So looking forward to it.
Awesome. Always a pleasure co-discussing with you. And then next up, we have our scribers and teaching points. So we have Vinny, first of all.
Hey everybody, super excited for everyone's case. Let's go.
Thank you. Yeah, let's go. Shreya, how are you?
Hi, Imran. I'm good. Yeah, I'm looking forward to the case as well. I'm doing teaching points today. Yeah.
All right. Thank you again. And Aaron, thank you very much for bringing a case. You want to unmute and just say hi and what's going on in your neck of the woods?
Hey everyone, I'm Aaron. I'm here with another case. Yeah, so I'm currently doing an outpatient cardio rotation. So I'm on my lunch break right now, and I was like, I'll go present a case. So yeah.
Awesome. Yeah. I hope you have time to have your lunch as well. All right. Let's get the whiteboard deployed and first aliquot. And Zachary, I'll have you manage the first aliquot.
Sounds good.
All right. So for our first aliquot, we have a 72-year-old female coming in for a generalized weakness.
Okay, lovely. So I think we'll start off by we've had this discussion quite often on VMR about a weakness and what it can actually mean. And I learned from this platform that weakness, firstly, the term is quite subjective, and people can use the term weak to mean a lot of things besides true low muscle power. So I think the first thing is to see, is there some sort of systemic syndrome? And just ask the patient to clarify, what does she mean by that she feels weak? Does she mean something isn't working, like in a limb? Or does she mean that she just feels fatigued, tired, and is there something else going on? So yeah, so it could be the complete center of gravity if you see on examination that there's true focal weakness with one arm not working. Or it could potentially be that it's just part of systemic syndrome, and any sort of systemic illness from head to toe could make somebody feel weak without there necessarily being low muscle power. And I think that would be quite interesting. So first thing, is it true weakness or not? And then to go from there, is there any other center of gravity of the case? And I think it would be interesting to have some blood work if there is no obvious focal weakness that we find in exam, because oftentimes a generalized weakness from a systemic syndrome might find some abnormalities in terms of their blood work, whether it be anemia, signs of inflammation, and so on. So yeah, I think it'd be interesting to know how long it's going on for, and if there are any other localizing symptoms.
Yeah, I really like that point that you started off from, Zachary. I think, is this really weakness? Define the weakness, frame this problem. And I think the key point here, what I kind of like to tease out from the age is, with younger patients below 50, above 50, what are the most common causes of weakness? So in a younger person, I would anticipate, the weakness, if it is a constant weakness. So sudden onset of weakness, maybe you're talking about maybe embolic phenomena to the brain. Is this something that's neurological? Whereas usually with an older person, a stroke is high risk, right? Due to certain diseases. Is there a background of diabetes? Is there a background of high blood pressure? Is there a background of embolic phenomena, atrial fibrillation, or something like that that can cause CVA? The metabolic phenomena, which you mentioned, is very interesting. So is there also a condition, and who is usually susceptible to metabolic phenomena? Again, it could be somebody over the age of 50 due to drugs, maybe due to decreased intake, or maybe there's loss of electrolytes such as diarrhea or a hypermetabolic process. So, and medications are notorious, right? The most common cause of, like, say, hyponatremia is HCTZ, one of the medications for high blood pressure. So it's interesting. We're on this side of the age spectrum, and these kind of things I'll be anticipating. Younger people sometimes I'll be a little interested in certain conditions which can feature like MS or these neurological conditions which can manifest in younger people, autoimmune, paraneoplastic, and so on. So I'm not going to really dive deep in this moment, but I'm just sort of using the age spectrum to sort of guide, like, where should I invest my cognitive energy and what strategy will get me to a diagnosis. So yeah, there's so much that's going to be anticipated. Labs will be helpful and so on, but a bit more history will really be key in trying to solve this case. Back to you, Aaron.
Great discussion, guys. So yeah, basically when we had this patient who was coming in for generalized weakness, we were thinking the same thing, like, what do you mean by weakness? Is this focal? Is this generalized? So we got more info, and for the first part of the HPI, 3 hours prior to arrival in the ED, the patient complained of generalized weakness accompanied by lightheadedness, dull right frontal headache rated at 8 out of 10 in severity, nausea, and some diaphoresis. There was no associated extremity numbness, weakness, blurring of vision, chest pain, dyspnea, or any other subjective complaints at that time. And I'll stop here.
So thank you, Aaron, for the next aliquot. Very well put together there. So what's interesting, this just happened immediately before coming in. So this really has an emergency ring about it, right? Sudden onset, 3 hours before coming, this weakness. Now, the associated features of this case really do lend credence to the theory that the answer may lie within the brain. Headache is within the brain. Vomiting centers within the brain. Of course, when you break down vomiting, you have the brain itself, the area postrema, and then you have the other centers like the GI tract and so on. So I think here we're trying to relate or pin each of these features to a certain organ. So I am worried about the brain, and the brain can be attacked in many various ways, right? And in a very sudden manner. So here, I think it'd be key to then maybe to do an exam to see if there's any signature of weakness, maybe in a certain territory, a certain extremity, flaccid weakness in one side, asymmetrical, which would ring with a possible brain attack syndrome. So I think at this point, I definitely will invest time looking at the brain as well. But is there something outside the brain happening? Always possibly could be, right? What kind of things can externally influence the brain? Metabolic. I mean, the body's like a ginormous car battery, right? You have electrolytes floating around which run the electrical system of the car or the body. So electrolytes may very well be, like initially hypothesized, could be influenced. And say there's a background of previous stroke. We haven't even gone into the past medical history. What if there was a stroke before, and now you have recrudescence of previous stroke syndromes? And I've seen this in patients before. So it's sort of like a pseudo stroke influenced by inflammation elsewhere in the body. Infection could do that as well, could flip the switch on symptoms of a previous stroke. I'm going to send the mic over to Zakariyya to see what he has in mind.
No, I absolutely love that. And yeah, I was just trying to think of, is there any way where this patient doesn't get emergent imaging? And right now I'm actually struggling to think of a way where we wouldn't want to immediately CT scan this patient, because she's given us a sudden onset headache that's extremely severe, associated with two symptoms that I always get worried about. Whenever I see somebody that's actually diaphoretic and has nausea, those two symptoms are not symptoms usually of a necessarily benign cause, unless you really have ruled out emerging causes. So that in somebody who's now having lightheadedness as well, I'm really worried that she might have had some sort of blockage in her brain and needs emergent imaging to rule out a bleed or potentially some sort of thrombosis as well. I think the exam would be quite telling if you can find any focality, but just to remember that a lack of any neurological syndrome does not necessarily mean you might not be having something serious. So you could be having a seizure, or something like a cavernous sinus thrombosis can absolutely cause a devastating neurological syndrome without necessarily the patient having any focal weakness. So I feel like our center of gravity right now is really, really on the brain, and that it's relatively unlikely that there's anything elsewhere besides that from just the history that we have right now. But I think just a simple exam to start off, get the glucose, get an ECG, because elderly patients with diaphoresis can have very atypical manifestations of cardiac disease, and just seeing what the vitals are as well. And yeah, I'm already starting to think about how can we get this patient quickly to a CT scanner. But excited to hear more.
All right. So this, I have another second part of the history, and I purposely separated these two aliquots because similarly, how you guys were thinking initially, like without receiving this latter part of the history, I just wanted to see how you guys were approaching this case. But after this next aliquot, I want to see how if your approach has changed or if you guys are still thinking of like the same things. So 2 hours prior to her arrival, the patient stated that she felt warm. So the relatives checked her temperature and noted a fever to 38 degrees Celsius, which is 100.4 degrees Fahrenheit, associated with onset of non-radiating epigastric abdominal pain, also rated at 8 out of 10 in severity, which was associated with nausea. There was no vomiting, chills, dysuria, hematuria, or bowel changes. She was given Tylenol 500 milligrams with slight relief of her symptoms. And in the interim, her relatives noted that the patient would not answer appropriately to questions. And when we clarified what that meant, the family said that when the patient was asked how she was feeling, she would just respond with moans, which is not usual. They say she's usually just able to answer and give a straight answer. And given these symptoms, the patient was brought to the ED for further evaluation. On review of systems, there's nothing else. There's no unintentional weight loss, night sweats, colds, no chest pain or palpitations, no cough or dyspnea, no vomiting, and no urinary symptoms. And I'll stop there.
Yeah, well, the plot thickens, and absolutely fascinating is that that really adds on a lot, because now we have a worrisome neurological syndrome, but we are actually starting to find evidence that there's abnormalities elsewhere. So I think first thing is I want an ECG on this patient just to make sure that there's no signs of ischemia, and I'd probably be ordering blood as well, especially a troponin. Again, elderly patients can have extremely atypical manifestations of cardiac disease. But in addition to just like a garden variety acute coronary syndrome, the one thing that worries me that if she's having epigastric pain, is this potentially related to aortic pathology, which we know can be complicated by stroke if the dissection extends into the carotids. So I think this patient is again more and more meeting the indications to get emergency CT imaging, and potentially considering imaging not just of the brain, but of the chest and abdomen as well. I think the inflammation that we've confirmed with the patient having a fever of 38 degrees is interesting. I'm wondering if it's persistent or not, because just something like a seizure could certainly cause transient temperature abnormalities that resolves, or is this potentially some sort of ongoing acute inflammation? And when we think of acute inflammation, I think we worried about is some sort of infection, but potentially also ischemia can cause that. So yeah, so Ravi, I think there's a lot here in the history, and I'm interested to see how you'd integrate that with the patient's presenting complaint.
Absolutely. I think you've done a wonderful breakdown, my friend. I think there now we've really flipped the script with this patient. We were primarily in the region of the brain, and now I think we can be rest assured this is probably a multi-systemic disorder. Remember, we were like initially investing in the brain, but we're like, wait a minute, we may have to step away from the brain and look at the body as a whole. So when we try and frame this with you have headache, you have generalized, and now the weakness is generalized, right? So there's many multi-system conditions which can manifest as weakness. So it's not focal brain-associated weakness. It's just like everything's weak. And usually we think of conditions where there could be weakness secondary to, maybe you mentioned inflammation. I was very glad you honed in on inflammation, which could be of infectious or non-infectious etiology, could this also be due to, we talked about the battery analogy, so electrolyte depletion, which could also be due to infection or inflammation as well. So I think here, these domains will pay dividends in trying to get to the answer with this patient. The fever is really helpful because that will really help us key in on possible infections. That was interesting. The epigastric pain, how much will that lend to making progress with this case? I don't know. But you think about a gastrointestinal illness, nausea also. Remember, I was trying to quickly break down nausea. So the GI area, the vestibular area, the area postrema, the brain, these are the centers for nausea. So maybe the nausea is due to the GI system. So you have to start thinking about various infections. And I kind of would like information as such, is there diarrhea? Is there constipation? Is there any travel history? Is there any exposure? And the immune system of this patient. Is there a background of immunocompetency or immunodeficiency, which will help us in this category of infectious disease? Now, autoimmune disease, it can manifest, although it will be rare, especially epidemiologically with this age range. Toxic metabolic, can they be drugs that are causing this kind of reaction? And then the other thing is like infection of the body or infection of the brain, encephalitis, meningitis, headache, could there be meningitis? And it could also have a multisystemic manifestation, nausea, abdominal pain, and so on. Maybe the abdominal pain is non-specific here. So I think right now we have our cognitive strategy in these areas, and I think a bit more history will help us to sort of gain some diagnostic clarity on this case. Any other thoughts, Zakariyya, before we move over for more information?
Yeah, I think I love that you brought up the patient's age and talking about immunocompromise. I think just to remember that patients in their 70s have some relative degree of immunocompromise. There's a concept of, I think it's called immunodehiscence. I might be saying it incorrectly, but you get some degree of immune dysfunction just by growing old. So that's why patients, as you get older, are just more likely to get a community-acquired pneumonia than somebody in their 30s. But in addition to that, the likelihood of somebody having either known past medical comorbidities or undiagnosed comorbidities because of their age, something like myelodysplastic syndrome, or any or more commonly like something like diabetes and chronic kidney disease, makes older patients much more likely to be immunocompromised. And just one last thing with the age is that elderly patients are much more likely to get multiple complications from a single process that leads to different symptoms. So somebody can get an infection, but because they're elderly, they might also become symptomatic from an electrolyte disturbance where sodium of 131 won't cause symptoms in someone young, but an elderly patient with other things as well might start to have symptoms. So I think it's very possible in this case that there might be multiple diagnoses in real life in somebody in this age group.
All right,
Please
back
tell
to
us
you,
more.
Aaron.
All right, wonderful thoughts. So for our past medical history, the patient has hypertension, type 2 diabetes, CKD. She has post-surgical hypothyroidism. When we asked her why she had her thyroid removed, she wasn't sure, but she's maintained on levothyroxine. She's also dyslipidemic. She also is an active case of pulmonary tuberculosis, which was diagnosed 1 month ago. So she's currently in her intensive phase of treatment. She also has vascular dementia, and she has diverticulosis, which was discovered on colonoscopy this year. And for her meds, I'm just going to list them all. She's on losartan, amlodipine, rosuvastatin, sitagliptin, metformin. She's on basal insulin. She's on keto analogs for her kidney. She's on levothyroxine. She's on combination RIPE pill, which is just a single pill with all the TB meds. She is on memantine, and she has Senecot to help her bowel movements when she's constipated. For her previous surgeries, as mentioned, she had a total thyroidectomy in 1976. She had a total abdominal hysterectomy with bilateral salpingo oophorectomy, secondary to a myoma. She had a C-section, no known allergies, and family history is only relevant for diabetes and her siblings. And for her social history, she's a non-smoker, no alcohol, no illicit drug use. And yeah, I'll stop there.
Zachary, I forgot who's going first.
I think it's your.
Oh,
it's you.
okay. All right. Yeah. I was like so enthralled by this case, I forgot the rotation. But what's interesting, like, so now at this juncture of this case, Aaron's presented very well the background of this story. So the story here now introduces a couple of interesting points, right? So this patient is being treated for TB, and TB can influence this case in two ways. Either there's a complication of TB. The second thing is complication of treatment. Now, putting that on the back burner, the other components of this history is that this patient, we had hypothesized what is the immune status of this patient, diabetes. Zakariyya mentioned a very lovely point of this immunosenescence, I think is the term. And I really appreciate you for bringing that up. That is a very valid point. So this patient is immunocompromised, so is ripe for any sort of complication of any condition. So TB again here, why would the patient being on treatment fail TB therapy? Maybe because the immune status is not robust here. So then you have to start thinking about what kind of conditions or what kind of complications can you have. As far as the drugs, you definitely would have to do a research of the drugs and see what kind of complications you could have. With TB, though, it pretty much can go anywhere. So if you start thinking TB could get wrapped up in the gut, TB could cause peritonitis, TB can cause pseudotumor-like conditions, TB can possibly go hole up in the brain here. So like you had initially hypothesized, Zakariyya, imaging will be key here to see. There's a vast possibility of different complications, conditions, or it may not be even TB related, but this could just be a red herring here. But it's very interesting, this layer that's now being presented. Any other thoughts, Zachary, on this aliquot here?
Yeah, I love the discussion on TB and nothing to add there, besides potentially that we might be heading down the road of an LP if the imaging isn't really revealing. But I just think the one other thing that just piqued my curiosity was the fact that the patient has had a surgical thyroidectomy, if I'm not mistaken. And I mean, I'd be interested to know what exactly happened. Did she have Graves' disease and have a radioiodine ablation, or did she have some sort of thyroid cancer and was the entire thyroid gland removed? Because potentially she could be at risk of complications if she, for example, had thyroid cancer. Could this be metastases to the brain, which is known to be one of the cancers that can cause hemorrhage? But in addition to that, whenever somebody is on levothyroxine, I want to know, is she taking the medications? What was her last TSH, T4, T3? And is there any chance that the patient could have a life-threatening complication such as a myxedema coma that can be brought about by any acute illness? So I'll be really interested to see what is her level of consciousness on physical exam. Is there any bradycardia? And have a relatively low threshold to get those bloods and potentially consider treatment if we are worried. And I think just in addition, when somebody's had the surgery around their thyroid gland, just to remember that next to the thyroid gland are your parathyroid gland, and they're also at risk of getting calcium-related complications. Relatively unlikely if the procedure was a while ago and she hadn't had any issues immediately afterwards. As usually, you'll get the hypocalcemia. It should happen quite quickly if it is if there's been a complication, and with time, it's unlikely to happen much later on. But yeah, I think getting a CMP and a thyroid test would be quite interesting. And if there wasn't any history of thyroid cancer and it was actually something like Graves' disease, then again, she has risk factors with one autoimmune disease for getting others as well. So yeah, just to keep that in the back burner.
Yeah, I think that's incredible. Anything is fair game at this juncture, and I think we have two opposing sort of theories: the TB, the thyroid, and I think more information will help share light. So while you were talking, I was like trying to frame this with this person. So we have fever, we have constitutional symptoms. How would this suggest in the domain of TB? Like, is this, we think of TB localized, we think disseminated. This could signal disseminated if you think about it, because it's a very systemic process at this point. If indeed this is something to do with TB. With the thyroid, it'd be interesting. Let's get more data and see what we can really dwell on in the next aliquot. Over to you, Aaron.
Great. So, for the next part, I'm going to give you guys her physical exam. So, while in the ED, the patient was actually nauseous and she was vomiting. Her BMI is 20.4. Her blood pressure was 180/80. She was tachycardic to 113. She's a bit tachypneic at 23. She was febrile to 38.1 degrees Celsius, which is 100.5 Fahrenheit. But she was satting well 99% on room air. She was awake, weak looking, not in distress. I mean, well, aside from the occasional vomiting, but she was just weak looking. Anecteric sclerae, pink palpebral conjunctiva. She had dry lips and oral mucosa. Her neck veins were not distended. As mentioned, she was tachycardic, but with a regular rhythm and no murmurs. Her lungs were clear bilaterally. Her abdominal exam, she had a non-distended abdomen with hyperactive bowel sounds which was still soft. However, she did have direct tenderness in the left lower quadrant without guarding or rebound. Her pulses were full and equal with no lower extremity edema, and a neurologic exam was unrevealing. And I'll stop there.
Yeah, I think fascinating. And in the last Alacot, we were talking about the complications of hypothyroidism. I think also just to remember, if the patient's on levothyroxine, could she potentially be on too high a dose or have taken more than she normally would? Because the one thing is we're starting to have again, somehow I feel like every time I discuss with Ravi, we talk about sympathetic toxicity, and yet again we're having a patient who has the triad of hypertension, tachycardia, and is having fevers as well. And that, to me, meets the criteria for me to wonder if the patient's having some sort of sympathetic toxicity. And a simple way to approach that that framework is there some sort of exogenous substance, and sometimes it can be substances in excess. So, for example, patients are taking too much thyroid hormone, or it can be deficiencies. And classically, the one we worried about is alcohol withdrawal, or is there some sort of endogenous substance? And in the last case, it was a pheochromocytoma. Classically, Graves' disease can cause thyrotoxicosis. But I just do wonder, with the triad of symptoms, if this patient could be having symptoms of hyperthyroidism and potentially be wanting to do the scores for to rule out thyroid storm. But then also then to remember that the most common cause of sympathetic toxicity is just simply anxiety, pain, and so on. The patient does have abdominal pain and so on. So if those things resolve with analgesia, then might not necessarily be the branch point. But yeah, Ravi, I think I'm actually interested to see how you'll bring in the left lower quadrant pain, and if you think that's a distractor or something that might be a pivot point for us.
Yeah, absolutely wonderful. I was thinking, what's funny this morning? I was like, oh, Zakariyya's going to co-discuss, sympathetic toxicity. He did such a great job. If you go back, we discussed a case in like a couple of weeks or a month before that. He had a prime example of a case of sympathetic toxicity, and he just broke apart that case using his knowledge of physiology, which was such a wonderful discussion. I really appreciated it because physiology is just such a game changer when it comes to understanding mechanisms of disease. So again, I was like looking at those vital signs. I was like, Zakariyya, every time you come on, it's sort of like there are other discussions. It's neuro or something keeps coming up. So very interesting. It just doesn't sound like an infection. When you have infection, you think of sepsis, vasodilatation, the whole cytokine inflammatory cascade. I'm seeing tachycardia, I'm seeing fever, but the blood pressure, I cannot explain the blood pressure. Then you have to switch gears and start thinking about what is wrong with the sympathetic system. Maybe in early sepsis, there can happen. So there's certain conditions, patient has a background of high blood pressure, and so maybe they're at their high blood pressure state. And eventually, with a few hours, you'll see them move over or transition to the hypotensive state. But at this point, if we take it at face value, these vital signs, you can't help but think about sympathetic toxicity and think about, you laid it out beautifully there, withdrawal, endocrinopathies. I'm not sure. I think we may need time. Time will be a great exposure or will expose the story of the patient. And if the blood pressure drops, the patient starts getting what we call toxic. Maybe there is a sympathetic layer to this case. Oh, sorry, septic layer to this case. But at this point, it's difficult to say. So yeah, the left lower quadrant abdominal pain. So the way I approach it would be then to sort of envision the organs that are in that area. And so what we have is the descending colon, sigmoid colon, muscle, fascia, skin, and could it also be referred pain? There was epigastric pain. Appendicitis usually can go to the epigastric region, umbilicus, but usually not to the left side. So common things on the left side, colitis, diverticulitis, those kind of things. Also, you have to be careful that it's not just if a patient vomits continuously and this patient has nausea, and if they're vomiting, they can have superficial abdominal pain. Other causes of superficial abdominal pain could be anterior cutaneous nerve entrapment syndrome, things like that, rectus sheath hematoma, but usually would be not just localized to one area, but usually will be maybe both sides or maybe in the epigastric. So I don't know how important of a finding exam does support your hypothesis generation and trying to figure out what is going on. But at this point, I'm a little confused where to really trek for the answer. So my compass is spinning and is not pointing in the right direction, or diagnostic compass, I would say. So interesting. I think let's switch over to the lab, see what Aaron has. Maybe that will point our diagnostic compass in the right direction.
Sure. Great discussion, guys. For just letting you guys know, this next aliquot will be the labs, and then the next aliquot will be the final aliquot. But I'll present that last aliquot, but before I give you the final diagnosis, I'd like to see what you guys think. So yeah. So for her labs, for her CBC, her hemoglobin was 14.8. And then we have a WBC count of 22,400 with a neutrophilic predominance with 93 neutrophils and lymphocytes 3. For her platelets, it was 265,000. For her creatinine, it was 1 with a BUN of 15. Her sodium was 140. Her potassium was 4.0, fluoride 100, ionized calcium of 1.13, magnesium of 2.1. Her ALT was 24 and her AST was 25. Uric acid was 12.1. Her UA was within normal limits. Her finger stick glucose was 208. She had an EKG done, which just showed sinus tachycardia with nonspecific STT changes. She had a trope done, which was 17.4, but the cutoff in our institution was 25, so she was below that range. And she also had she just had randomly 2 labs with her from outside. She had a TSH of 14.4 and an HbA1c of 9.2, which was done, I believe, 2 to 3 weeks before her presentation. Yeah. And also, actually, she also had imaging done. She had a chest X-ray, which the impression was bilateral upper lung densities, which may relate to an infectious or inflammatory process, and an abdominal X-ray, which revealed a non-obstructive bowel gas pattern as well as fecal stasis. And I'll stop.
All right, a lot of information. Again, very wonderfully presented, Aaron. All the important data points that likely will help us to figure out what's going on, find the needle in the haystack. So you definitely, with each aliquot, you're sort of moving the diagnostic goalpost. Just when we thought brain, abdomen, infection, systemic disease, I think the Y count is mega here with fever. The pretest probability for infection is quite high in this, and currently in this patient. So again, where would the infection be? We talked about, could this be, or Zakariyya mentioned, maybe pneumonia? This patient is immunocompromised. We're not having any signal in the lungs. Signal is all in the abdomen. And I think imaging will really pay dividends in trying to figure out what's going on in the abdomen. If we sort of concentrate in the left lower quadrant, maybe, then these conditions causing sepsis, Y count is really high in this case. So I would be very worried about complications of infections like bacteremia or abscess formation or tissue damage, infarction, ischemia, and so on. Now, there's endocrinological testing, which is interesting here with the TSH that's elevated. I think we would have to pair up at least the free T4 in this case to help. But just with the high TSH, the framework for high TSH we have to worry about is there, is this patient in a hypothyroid state? And the patient is taking supplements, so maybe not getting enough thyroid, but it would not manifest in this condition with this, what Zakariyya mentioned, sympathetic overdrive. So at this point, the one thing I could really ascertain from this patient is the exam showing dry mucosal membrane. This patient is dry. The labs do correlate with that. If we look at also hemoglobin is generous in this patient and concentrated, likely uric acid here. Is this going to be system one thinking uric acid? We start thinking of breakdown, tumorilysis syndrome, these kind of conditions, but it could also be attributed just to dehydration and at this point. So I'm going to see what Zakariyya has in mind while I kind of dwell and listen to him, and I will kind of digest the information further. Over to you, Zakariyya.
Yeah. So I think the one thing is with this history of the patient having pulmonary TB, I would have actually wanted to just know how exactly was that diagnosed. Was it actually confirmed testing with a sputum gene expert or AFP, or potentially even the best test being a TB culture being positive, and then for how long she's been on treatment for? Because absolutely this patient could have TB peritonitis and have potentially TB meningitis, or potentially even something more serious like a tuberculoma. And imaging would be really revealing as well, in addition to getting potentially an LP. But I think just the other thing is just to remember that the most morbid causes of neutrophilic leukocytosis are ischemia or infection, and we absolutely need to make sure those are ruled out. It is also possible just from a severe stress response with sympathetic surge to get a raised leukocytosis that will then sort of resolve as the sympathetic stimulus goes away. But that sort of is a diagnosis to completely rule out. And I think just the one last thing is that we know if this patient has confirmed pulmonary tuberculosis, that she actually does have an ongoing infection. So it might not necessarily be atypical for her to have a raised white cell count and size of infection, and that this might not necessarily be any sort of infection currently at all, and just all related to her pulmonary TB. But yeah, I think it would be really important to make sure that there's no evidence of TB elsewhere in her body besides her lungs. And yeah, so I think interested to hear more.
Yeah, just to add to those, two teaching points come up. So approach to high uric acid, there's a 3 U's that come up. So one is uptake, one is usefulness, so used cell turnover, aka cell turnover, and 3, urinary excretion is decreased. So if we just in isolation look at the uric acid, how does that help us? So could there be decrease in urinary excretion, dehydration? Maybe we're in that domain and we don't have to really probe this further. It's not going to help us to get to the decision. And then TSH here being high, definitely get the next test. Is this going to help us as well? So what exactly is a TSH? TSH is a gland is saying like, you're not listening to me. So the thyroid is like, you're not listening to me. So more TSH screaming, telling the thyroid to make more hormone. You're not making enough. So we're shouting at you, make more thyroid hormone so my TSH can go down. So it's just a feedback mechanism where the pituitary gland is screaming at the thyroid gland to make more hormone so that the feedback mechanism can work in that case. Let's see in the next aliquot. I think imaging will also be key, and also the free T4, T3 will be helpful as well. Any other thoughts, Zakariyya? Very interesting case, Aaron. It really has me challenged.
Nothing else. Epic discussion on the UA and the approach to TSH. I love that.
All right, great discussion, guys. So this one is actually the final aliquot, which will just reveal I'll be telling you guys the CT findings, but I won't tell you the diagnosis yet. I want to see what you guys think afterwards. So for her, she had a CT of the abdomen and pelvis done, which showed non-inflamed colonic diverticulosis. She had circumferential bowel wall thickening with associated intraluminal narrowing and minimal perilesional fat stranding densities along the sigmoid colon. She had fecal retention as well as an enhancing left adrenal mass, measuring 3 by 3.1 cm. And I'll just stop there and see what you guys are thinking.
Interesting. I think it's my turn to go. But yeah, so Zakariyya, you asked me about the left lower quadrant. That exactly is where area of interest is. So it appears to be two findings. One is incidental, right? And we talked about earlier on, where does TB go? TB can go to the adrenal glands and cause adrenal dysfunction. So the other thing is this mass. Is it a mass that is compromising the layers and causing insufficiency? Or is this a mass that is hypersecretory? So interesting. Again, Zakariyya, you're bringing sympathetic overdrive and sympathetic toxicity to the discussion. But I think, yeah, everything is signaling there's major infection happening within the area of the bowel. Are there any other kind of conditions that can emanate from the bowel and cause endocrinological issues? We have to start thinking about certain neurosecretory conditions where that may happen. But I'm going to turn the mic over to Zakariyya for any input on this case.
Gosh, so I saw that Aaron in the chat said that the patient was diagnosed with pulmonary TB based on a productive cough for about a month, as well as the X-ray. I think it would have been interesting to look at the X-ray to see are there any sort of features that are quite suggestive of primary pulmonary tuberculosis. It can often be quite classic, especially in endemic areas. And I'm assuming the fact that she was empirically started on treatment would mean that she is in an endemic area. Here in South Africa, regularly patients are empirically started on TB treatment based on their comorbidities and the clinical picture. But we don't actually have firm confirmation yet. So I'd definitely be wanting to get sputum, send it off for gene expert. It's interesting that there's now discussions going on about whether there's use of urine lamb testing in patients that are not HIV positive, but who have other sort of underlying diseases of immunodysfunction, like this patient has with CKD and uncontrolled diabetes. But that's still relatively up in the air. So I don't know. I don't really know if there's evidence for that, but it's a very useful test because if positive, it's very specific for the diagnosis of TB. And if this patient actually does have pulmonary TB, then many of the findings that we see in the on the CT with the bowel wall thickening could potentially be suggestive of that. But the one thing I think when I think about TB in the adrenal glands is I usually think about adrenal insufficiency, with the patient having hyponatremia, hyperkalemia, and becoming hypotensive with relatively lowish glucose. And if anything, this patient seems to have the opposite. So I'd be interested. Is it possible for a mass compressing on the adrenal gland to sort of cause the opposite, where you actually have a sympathetic surge with your catecholamines being released? It's not something I'm aware of. I'd have to research to find out if that's possible. But yeah, I think I'm wondering again if we should just be getting urine metanephrines to rule out a potential pheochromocytoma. And then also remember that if we haven't actually confirmed pulmonary TB and the abnormalities that she has in the lung are either some other type of infection or potentially some sort of malignancy, could this patient be having something, for example, like small cell lung CA with mets to the adrenal gland? Very, very possible. So yeah, I think getting confirmation on that TB would be really telling on where we would go next. Anything else to add, Ravi, before we hear the final diagnosis?
Yeah, a very interesting phenomenon you talked about. Yeah, we talked about the tumor or TB just compressing. So it can emanate from tissue within the adrenal gland, or it could be a secondary invasion of the cortical layers. Remember remember the physiology or anatomy of the adrenal gland, and we have the zona reticularis, and I'm forgetting all the different layers, but each layer has certain different hormones, and then you have the medulla, where a lot of the sympathetic hormones may be stored. So cortisol and so on may be affected, aldosterone in the upper layers, and then you compress further down. But what you mentioned a very interesting concept there. Like in the initial stages, there's hormones there, and as it impacts that the layers, could it cause a massive release of all these hormones and cause this sympathetic discharge? Very well, we may be in the initial stages, and then once they deplete, we go into this insufficiency stage. So exaggerated phase, and then in insufficient stage. That's interesting. That may very well be at maybe very well causing this. And then if we do go back to the space of TB, TB could manifest in the gut in this manner and cause a sort of a pseudo tumor-like manifestation. TB could affect the adrenal gland. Neuroendocrine tumors in that area, I mean, we will look for certain features. I sort of deployed this earlier, but it doesn't fit. You think about lipomas and so on, and then hypersecretory, a lot of diarrhea, gut loss of electrolytes, hypochloremia, and these kind of things. But we're just not seeing that here. So I think this is a very robust explanation for this patient, and kind of excited for Aaron's revealing of the diagnosis. Over to you, Aaron.
Yeah, those are some wonderful thoughts. So for the diagnosis that my team settled on was actually just infectious sigmoid colitis, and we were initially thinking about stercoral colitis as well due to the marked fecal retention, but we actually were just able to fix that with some laxatives. She was able to defecate. So we settled on infectious sigmoid colitis. The patient was started on IV antibiotics, and she actually did improve. Her symptoms were improving. And as someone mentioned in the chat earlier, we were guessing all like her neurological symptoms and just generalized weakness were just attributed to this just feeling generally ill overall. And to answer Zakariyya, we did end up getting sputum, and her MTB PCR was negative. And we also got blood cultures initially, which were also didn't grow anything. We after her antibiotics, we rechecked the CBC a few days later. Our WBC count went back down to around 9. So we weren't really thinking of we wanted to do obviously to work up her adrenal incidentaloma on the left. But yeah, since this was a charity patient, it was a hospital politics thing, and with the budget and issues like that. So this admission was focused more on just getting her better from her infection, and we wanted to do further workup with her for her adrenal incidentaloma as outpatient. But yeah, this was a fun case that I enjoyed because presenting with generalized weakness in an elderly female with so much past medical history just makes you think of literally all the systems that are involved. And the addition of the recent TB diagnosis was also concerning. Could this be a presentation of extrapulmonary TB? And then, I also forgot. I mean, I knew she had her diverticulosis, and I was like, oh, left lower quadrant pain, diverticulitis. This must be. But I don't usually have infectious colitis in my differential, so I guess that just added it to my differentials. Always think of like infectious colitis for any part of the colon. Yeah.
Wow. I think we had an exaggerated cognitive response, Zakariyya, but it's good. It's good. It's always good to leave no stone unturned, because you never know. The next case may be as complex as this. So the interesting points of this case, that this TB wasn't really TB, right, Aaron? It was just kind of a presumptive diagnosis without confirmed testing, which is very dangerous in this case. You always have to be careful because you may expose the patient to harm. And then the second thing is the exam really did focus our attention on the sigmoid colon. I think it does really help in trying to then anatomically dissect that area and see what could be contributing to disease. So white count plus fever, framing that abdominal pain, it gives you the likely answer, that area. The complexity added here was a false diagnosis. Actually, of TB, which brought in more confusion. And you see how that false, a false positive of diagnosis, TB diagnosis, was making it more difficult to come to a diagnosis of the patient, or was going to push further testing, which is unnecessary. So walking back, confirming, like Zakariyya, that was a great thought you mentioned about making sure the TB is real TB and not just based on the imaging and the symptoms. So walking back, retesting the patient, confirming that it's not TB, and then just comfortably settling on this diagnosis of sigmoid diverticulitis. The blood pressure really threw a spanner in the works there, because usually the patients that blood pressures are tanking, and this patient's septic, the white count is high, and this is a 72-year-old patient. They don't compensate as well as younger patients. So I wonder if the blood pressure did drop later, because sometimes that may happen. Immense pain, blood pressure's high, and then eventually the septic course overtakes the patient, and then the blood pressure tanks. Did that happen at all, Aaron?
Actually, I believe she was actually even started on a nicardipine drip at first because we couldn't control her blood pressure. It was just very high.
Just very
It was
high.
like
Okay.
when she was getting her CT of her abdomen, I remember she was like screaming in pain, and then they were just checking her BP was like 180s, 190s, and she eventually had to get a drip, and I think we were able to take it off eventually. But yeah, her BP stabilized to like 130s. But yeah, right before discharge, I remember she did have an elevation of her BP to like to the 200s that required clonidine. But so we watched her a bit more. But yeah, she ended up getting discharged. So I feel like for me, maybe it really is that part, like her adrenal mass is contributing to that. So we just encourage her to please come back for outpatient workup, because we don't want your BP to be uncontrolled like that if it's actually something else causing that.
Very interesting. Yeah. So the adrenal mass is left to be diagnosed. Zakariyya, any reflections? Amazing discussion, by the way.
Yeah, thank you, and thank you, Aaron. I have to say, I really appreciated this case because it was real life. We here talking at length about pheochromocytomas, anything, but at the end of the day, the goal is to help make the patient feel better. And yes, there might be something serious underlying with some sort of adrenal dysfunction, but she was started on antibiotics, she improved, and you actually did the most important thing and got her better, which should be our goal. And in addition to that, it just shows that in patients with numerous comorbidities, this is kind of how it often plays out, is that it's difficult to find an exact cause of each and every symptom and all the abnormalities you found in the blood work and the imaging and so on. But just it's all related to age plus comorbidities and one illness causing something else and sort of releasing this cascade. And when you start to reverse the cascade, the patient's symptoms start to go away. So really, real life and very well presented. And thanks, everyone.
And we'll turn it over to Shreya for teaching points. Thank you, Shreya.
Yeah, so we had a patient of 72-year-old female, who came for a generalized weakness. So whenever we have weakness in a patient, we should think about whether the weakness has come focal, like coming limited to the limbs, or is it generalized, or is it associated with any systemic symptoms. So causes of weakness could be metabolic, like electrolyte abnormalities, some medications could cause that too, or is there any systemic syndrome underlying the weakness? We should inquire about that too. And considering the age of the patient, autonomic or neurodegenerative diseases like multiple sclerosis or vasculitis could be a cause of the weakness. A patient can present with weakness initially too. So patient also had a headache with nausea and vomiting. So whenever weakness with headache and nausea, vomiting is there, we should think of localizing the lesion to brain due to a raised ICP. That could be infection, mass, or stroke. So imaging is really crucial to rule out bleeding or ischemia. Patient also had epigastric pain, which makes us suspicious of aortic pathology like dissections or a myocardial ischemia. So troponin ECGs are crucial at this point as well. So age itself is a immunocompromised state due to immunosenescence, which is due to aging. The naive B cell, T cells, and all those dendritic cells, macrophages, start worsening their function, and so the patient itself can be in an immunocompromised state by age, and that could lead to more worsening of his symptoms and more presenting of illness. So the past history, regarding the past history of the patient had TB. So with the present complaints, TB and its treatments, complications should be considered as well, like TB meningitis, peritonitis. With hypothyroidism, we should consider possibility of thyroid cancer in a long run, in a long course, and that's why levothyroxine intake should be inquired as well. So patient had sympathetic toxicity with increased vital signs, and then that could be due to adrenal pheochromocytoma or thyrotoxicosis. And patient also had left lower quadrant pain, which could be due to descending colon, sigmoid, skin, muscle, or referred pain. So adrenal mass with sympathetic surge can also be the cause of lower quadrant pain, left lower quadrant pain. High uric acid can be due to either increased intake, increased resorption, or decreased excretion. TB could present like a pseudo GI tumor, and yeah. So the diagnosis was infectious sigmoid colitis, which could also be a presentation of extrapulmonary TB. And there was no positive blood culture, and so the CT findings were we also had adrenal incidentoloma, so that made us think about the patient's past history of TB, which could be adrenal mass, but the adrenal TB most commonly causes adrenal insufficiency. So we should consider that maybe there is an adrenal mass that is causing exaggeration of the catecholamines release, and with hyper exaggerated phase followed by insufficiency. So yeah, great case, Aaron, and yeah, thank you for the discussion.
Thank you, Shreya. Wonderful job. It's just amazing. Truly international case. We have Brazil, India, South Africa, USA. We have truly international crowd as well. So very, very amazing to discuss this case with you, Zakariyya, today. I know it's evening in South Africa, so have a great night. And everybody be back tomorrow. I think there's a double header. There's Jeffrey with Duke Rheumatology and Charmin and Keaton. So please do show up for that one and increase your learning. Have a great rest of your Tuesday, everybody. Bye.
Bye, everyone.
Bye.